Hi, it's me, Ingrid Line of P, and I wanted to talk about autistic people and visits to a doctor, specifically. Not healthcare in general, but a little bit about that, obviously, because it's part of it. I feel like I am qualified for this discussion because I am a late diagnosed autistic person, got diagnosed 3 to 4 months ago, almost 4 months, at the age of 28. I am a medical doctor, a resident GP doctor. I've been working for about 3-4 years as a doctor. I have gone through all of medical school. So total, I've been in the field of healthcare for 10 years. I have been on both sides of the medical visit, both as a doctor and as a patient. And I have had patients who are autistic, and I know that because of their journal. The reason that they came to me was not because of their autism, but because of other medical difficulties. And I'm talking about physical difficulties, symptoms. But there might be some autistic people that I have met also for their mental health. This video will be a little bit more about somatic or physical health, but they're not that different actually. I work in public healthcare, and I've always worked in public healthcare in Sweden, so I have a little bit of a different perspective than maybe private healthcare or of an American doctor. I am currently at gynecology that is private, and I know that there's a slightly different focus and goals, and the patient visits might be a little bit different in private healthcare. But yeah, I'm going to focus on what I know. So that's public healthcare. And I think that a lot of autistic people often don't have the means to go through private healthcare. But anyway, I first want to start with the fact that I know that a lot of autistic people have medical trauma. A lot of people in general have medical trauma, but especially autistic people. And that's because of misunderstandings that happen. Some of them worse than others. And yeah, these misunderstandings, I think, unfortunately, are kind of baked into the criteria of autism, both the communication difficulties, the sensory difficulties, or differences, depending on how you say it and how you see it, and also the kind of repetitive, rigid thinking in a way. So first of all, I wanted to talk about why I was interested in this in the first place. And it was because I'm going through this book. I have videos on my channel. It's a book by a neurotypical, not great. And sometimes she says things that infuriate me, okay? And one of those things is that she had an example of an autistic person who goes to a doctor and has to shorten her story for the doctor. And I was like, no, don't shorten your story because of the doctor. Sure, a doctor's visit is often only like 15 minutes, and so you don't have time to say all that you need to say. However, I think it is not your job as the autistic person or as the patient in general to decide what is relevant to the doctor or not. You need to take up what you think is important, because you can't guess what the doctor is going to think is relevant or not. I've had too many patients, both autistic and not autistic, ask for me to forgive them for speaking too much or talking about things that aren't relevant. Okay, you're allowed to talk about whatever you want to talk about in a doctor's visit. However, the doctor might interrupt you or might steer the conversation towards other things. If you feel like you're being silenced and this is extremely important for you to say, then say it. okay? But the doctor's job is to kind of figure out what is relevant for their diagnostic process. So they will steer you in a certain direction. But if you feel like there's something that is missing, then say it, okay? I don't think that they will get mad. Obviously, what I'm talking about is situations where you have a good doctor. There are certain doctors who do not listen and who are impossible to have to do with. My advice would be to change doctors. But yeah, you can't reason with somebody who is just a problem, you know. To have a conversation, to have a meeting, you need two people who are willing to understand and respect each other. And unfortunately, that is an ideal situation in this world. So I'm well aware of that, but I'm talking about a situation where, you know, you have an okay average doctor. Or even better than average, because maybe the average doctor is not good. I don't know. I don't have the statistics of what is a good or a bad doctor. But anyway, so I think that I was angry at what was written in the book because it's not the patient's job to decide what is relevant to say or not. Because that is way too much responsibility to put on the patient, you know? And I don't think that that is taking away the patient's power, because it is all about patient autonomy. Okay, you have autonomy over your body and over your life. But the conversation, in order to get a diagnosis, needs to kind of be steered in a certain direction. But so I don't think that it's good to decide, oh, this is what the doctor will want to think is relevant, because you can't really know, okay? Maybe the fact that you have a dog is extremely important in this situation, you know? But you wouldn't know, you know? You haven't gone through 10 years of medical school to like know that the dog was an important part of this. So just talk about the dog. If that is important to you, then talk about it, you know? So we learned in medical school, in Swedish medical school at least, that a patient visit should go sort of like this. First, there's the patient's part, then there's the doctor's part, and then there's a mutual part. And that doesn't mean that in each part that there is somebody who is dominating and hurting the other person or harming the other person by their controlling behavior, okay? Unfortunately, that is way too common. Rather, it's more like there's a focus on who is taking the initiative in each part. So the first part is the patient. The patient, I think, should be given a lot of time to talk at the beginning. And actually medical students are much better at this than people who are more, you know, skilled and later on in their career. And that's because, unfortunately, later on in their career, they start getting impatient because they've seen this before so many times. While medical students, everything is new to them, so, and they're less likely to interrupt you if they're a medical student. But we went to have a long discussion. So the patient gets several minutes, hopefully, of uninterrupted time, of like maybe interrupted by like, oh, how difficult that seems, you know, or, you know, these kinds of affirmations. Then we slowly get into the doctor asking open-ended questions, like, tell me more about this pain, or, you know, or can you describe this pain, like how long you've had it for and such. And then there's more discussion. Then we get slowly into the doctor's part, where the doctor will start asking more yes-no questions, like, do you smoke? Do you have blood in your stools? You know, yes, no, okay. And then we get into more of the doctor's part, which is the examination. Now it's a little bit silly to call it the doctor's part, but it's the doctor that's taking the initiative, okay? You need to feel like you have bodily autonomy and that you can say no to different examinations without judgment. However, the doctor might want to explain a little bit more, like why this is important. So I need to do a per-rectum so that I know how your colon is working, because we are checking your abdominal problems. Okay, so you might be met with some resistance from the doctor, but the reason is maybe not to invade your body, but rather to explain why this is important. You don't want a doctor who does more invasive things than is needed. However, sometimes these things are needed, and you can say no, but that will have negative consequences. So they do the examination, and then we come and sit back in our chairs, basically, and we get to the mutual part. And the mutual part is basically wrapping a present up, is what I heard in medical school, okay? It's basically first saying, oh, you came here because you had back pains and nothing worked. The second is, we have done this and this and this during this visit. We have checked your back, and we are going to take some blood samples. And I would like you to remember this, or like, please do these things. So take this medication. You will be called for an MRI examination or something. And I will call you back when I get the results or something like that. And then it's time for questions, where it's like, do you have any questions? And then if you're a really good doctor, then you can say, can you summarize what we have talked about today? And that will make sure like the patient has taken in the information. So that's how we've been taught about how a patient visit conversation should go. This is just theory. Obviously, in practice, that's not really the case, especially if a doctor only has 15 minutes to see you. A lot of these steps will be extremely shortened or even disappear. But I'm talking about how, a certain code of ethics should exist in like how this art of medicine should be performed. So I think that it's important for autistic people to kind of have a rule in mind, or kind of have what to expect during a doctor's visit. And that might be helpful for some of you. For some of you, that might actually be frustrating, because you'll be like, well, that's never what happens when I go to my doctor. And sure, that might not be what happens when you go to your doctor. And I'm sorry about that. But that is maybe one of the reasons that you're getting into misunderstandings with your doctor, because this isn't what is actually happening. I can't speak about people and doctors in other countries. I'm just saying about like how we were taught, and how I think could be a good idea for doctors to work. So that is about how the conversation should go. Then I think that as I said before, autistic people have a difference in focus. And so that might lead to autistic people focusing on a certain aspect as opposed to another aspect. I am going to be talking about some of my patients, but they're going to be kind of like, not really the same case and not really the same person either. I'm going to be kind of muddying the waters so that nobody can know who it is I'm talking about. Let's take, and I'm going to mix certain patients together to make it even more muddy. But so the focus might lead to an autistic people wanting to know about a certain thing rather than another. I've noticed how conversations with autistic patients are different from conversations with neurotypical patients, okay? And that's where I'm drawing my experience from. So a certain autistic person might look for healthcare because they got a spot, a freckle on their foot, and it's a new freckle. And they've been taught that if you get a new spot on your skin, you need to go and look for a doctor because it might be a skin cancer. However, this was just a freckle, and the patient might have been around 16, and a person had been diagnosed with autism. And I realized, without looking in the journal, I didn't know that this person had autism. I realized, okay, this person has a different way of seeing the world and a kind of a rigid thinking, kind of a black and white thinking, because it was this patient, he heard a rule that this is what you must do in this case, but hadn't thought about all of the nuances behind this. And he was really worried that he had skin cancer, even though he was very young, and also his freckle looked nowhere near what cancer would look like. And so I explained during my visit what I'm looking for, and that there are more nuances to this rule than just, if you have a spot, go to your doctor. There's also the spot should look like this, and not everything that looks like this is cancer. So there is nuance in this. So that might be both difference in focus and rigid thinking. Another thing is that some autistic people might really hone in on a certain symptom that most neurotypical people will not hone in on, and then completely disregard other symptoms which a neurotypical person might find extremely banal, okay? So an autistic person, I'm talking about myself here now, might be really feel like it's really awful to have a stuffy nose, when really they are sick with a fever and coughing and have pneumonia. I didn't have pneumonia, but I'm just saying that for me, having a stuffy nose is like the end of the world. And I could disregard having a fever if I didn't have a stuffy nose, And so our sensory differences, this is where sensory differences come in, of you might hone in to a certain thing that you're hypersensitive to, and completely disregard things that you're hyposensitive for. And I noticed this in myself, I noticed this in the patients. I'm going to take another fictive example that might be a little bit similar to one of my patients. It's a person who has IBS, and IBS is very common in autistic people compared to the general population. And she has IBS, but she has, let's say she has a fever, and she hates having a fever. That's her worst thing ever. She is hypersensitive to temperature changes, okay? Let's say that, okay? She's hypersensitive to temperature changes. However, she is hyposensitive to pain because she's so used to having pain all the time because of her IBS that she doesn't notice that she gets an appendicitis. Because she has the appendicitis, she goes to the doctor not feeling the abdominal pain is worse, or maybe thinking, oh, it's a bit worse today, but sometimes it's worse. And she goes to the doctor with only because of fever. And this isn't the typical presentation of appendicitis. The typical presentation is pain and in that quadrant and such. And, she has fever, which is something that you can have when you have appendicitis, but not always. And so it gets missed, let's just say, because of that. And the doctor doesn't even think of feeling the stomach because he just thinks, oh, it's IBS. Kind of, lousy doctor to not like go through the whole body when there's an unclear fever. But let's just say that this doctor is not a great doctor, and he just says, oh, you have a cold, because she happens to have allergies and is always stuffy nose. And so, I don't know about the fever though. Maybe it says that it's, it's the flu season. It's the flu season. So we all are about to have some fever. So maybe just take some paracetamol or acetaminophen, if you say it in American. Take that and, stay home and you'll get better soon. And then it ends up that her appendix ruptures and then she has to go to the hospital. Okay, that's not great. Okay, this isn't patient's delay, this is doctor's delay. The doctor should have done more, sure, but also we can't really blame him for, not thinking immediately about appendicitis because it wasn't a typical presentation. He could have been a little bit more, gone deeper into the story and maybe taken some blood samples or something rather than assuming a certain thing. However, I can understand that it wasn't like the textbook. We see this in other patient categories. So we see this in heart attacks for women are not nearly as studied as men's and are often misdiagnosed because the typical presentation in the textbook is the typical chest pain, which a lot of women do not experience when they have a heart attack. So that has led to doctors missing that women would have a heart attack. So the sensory differences lead to misdiagnosis, and that is because our doctors, including me, are trained on the presentation of neurotypical white cis man, okay? And anything that falls outside of that will be an outlier and will be more difficult to diagnose. So it's just that I think that a lot of doctors don't think about neurodivergence as something that will affect physical health and the way that it is described and the way that it is felt. Okay. It is a slippery slope though, the fact that sensory differences are a thing, because this has been done before in that Black people were thought of as not feeling as much pain, as having thick skin, and therefore not receiving as much pain medication for the same condition as a white person. So, there is a danger in categorizing people and going according to that. I think that doctors need to work towards having individualized, and also evidence-based medicine. So not going according to discrimination or according to, some biases that you have, racist biases especially, but it is still the case, unfortunately, that these things happen. That somebody who is a Black, a woman, overweight, and autistic might not get the same treatment as somebody who is more the textbook definition of a typical person. And so it's hard because we want to get into more of a individualized medicine, However, a lot of medicine is based on putting people into categories because that is helping with the diagnostic process. We need to put people into categories. Like children need to receive another kind of care than elderly people or than middle-aged people. And there are certain conditions that are only present in women because they have these organs as opposed to men, but we have to be careful about the discrimination that can come from that. And so I think that that's why there are so many misunderstandings, is the sensory differences make the symptoms different from the textbook. And autistic people have difference in focus. So they might be entirely focused on a certain symptom as opposed to another. And also they might, I'm saying we, basically we, we as autistic people, might seek help for something that a neurotypical person might find completely stupid to seek for, when actually this is really important for us, and the doctor might not understand that. That's because we make different connections as autistic people, and so we have different, from what I've seen, we have different kinds of worries than a neurotypical person. In the same vein as the difference in focus, I once had a patient who really was afraid of having an STI, and one of those STIs was herpes, and actually herpes is really easy to treat if you have it, but it ends up that I just said the word that it is not herpes, and that really stuck in this person's head that it is herpes, when actually I had said the opposite. And so as a doctor, you need to be really careful about your wording of things, because I said it's not herpes when I shouldn't have said anything at all. But I think that it's important to know what is the fear of the patient. And this is something that we also learn in medical school, to get the thoughts of the patient, like what the patient wants from this visit, what are the fears of the patient, and what the patient thinks that this might be, because you get a lot of information from that. And if your doctor doesn't ask those questions, then it can be good for you to say it yourself, like, I think it might be this, I'm really worried about it, and I'm worried about it being skin cancer, and I would like you to look at it, maybe to do an x-ray or something. And the doctor might say, we don't have a need to do an x-ray. And we get into muddy waters here, because sometimes the doctor will have to say no to certain requests because the doctor feels like this is not medically relevant. And I don't know really what to think about that, because I often have to say no to patient requests because we don't have the money for all these requests to be fulfilled. And then it so happens that then, the doctor did not do this, and then it ends up that was extremely important to do that. And doctors are only human, and medicine is fallible, especially public medicine is very fallible. We're told to restrict on testing. Also, certain tests lead to problems. So, too much testing is not good either. And, we are only doing our best. I mean, doctors are not machines, so there will be a problem. But I do understand people's pain about and suffering caused by this, because it leads to misdiagnosis and waiting too long for treatments for something. But that is similar for neurotypical people as well. So it's just that it is hard to advocate for yourself as an autistic person, and I'm well aware of that. So I try to have some extra compassion, try to understand the thought process behind what the patient is saying, regardless of neurotype. And I try to do my best to catch what the patient wants from this visit, and try to do my best to treat the patients and figure out what it is with the information that I have. The work of being a doctor is difficult. Now, something that is also a problem in autism is delayed processing, which leads to maybe after the visit, the patient finally realizing, oh, this is what I wanted to say, which, is not great. And another thing is PDA, which leads to not wanting to do certain things that are actually important for our health. I do find, though, that PDA in general maybe is like a thing of the moment, and it might, it doesn't need to be consistent over time. So it leads to difficulty in actually doing what is perceived as a demand from the doctor. And yeah, I don't really know what to do about that. You shouldn't do anything that you feel really uncomfortable with. However, certain things needs to be done in order to have the best possible health. So I don't know. Anyway, that's it, I think. So we've talked about sensory differences. We've talked about, communication differences. You shouldn't feel like you need to mask with your doctor, but I know that this is difficult because, we live in a neurotypical society, and often the best way to get your point across is by masking. You will have to do some kind of masking because this isn't somebody that you can immediately trust, maybe. But it just makes the doctor's visit much harder on you if you're masking. I also think that the repetitive nature of things and the rigid thought process, rigid thinking and different connections, different thought process makes it difficult to have a successful doctor-patient visit when it comes to autistic people. But I think that maybe with time, doctors can start gaining awareness for this problem, and also to start learning about how to change things. And maybe society will be so accepting in the future, or accepting enough that maybe the healthcare might become a little bit more adequate. I don't have many hopes, but I give some hope to it. I'm aware that the situation is really bad right now, and probably will be for a good while in the future. But I'm trying my best, and I hope that there are other doctors who are also trying their best. Anyway, so that's it. Please tell me in the comments if there's something I've missed. If you do have medical trauma, sure, you can write it in the comments. YouTube might erase these comments though, so I'm not the one who's erasing the comments, just so you know. Don't feel like I am erasing them, because I'm not. If I erase them, it's often because they are insulting me which I don't think that these comments about medical trauma will be insulting me. Just talk about what you feel comfortable talking about. Don't go out of your way to dig up something that might make you feel vulnerable or, scared for your privacy. And be civil to each other in the comments. Okay, so have a great day, everybody. Bye.